Does anybody see mountains in the ECG? Yes. ST segment elevation. So this is a ST segment elevation MI. Okay. So what is this basically? When there is a myocardial infarction, basically patient is having a heart attack. Initial stage, you will have a hyper. I told you about P wave, QRS, and T wave. So the T wave alone will start becoming hyperacute, or you'll have a tall T wave. Very rarely, patients will come in so early where you're able to identify a hyperacute T. These patients need to be observed and an ECG needs to be repeated so that we can see the next phase in acute MI, which is nothing but the mountain which I talked to you about. The mountain is nothing but the elevation of the ST segment, the ST segment elevation. So that is what we are now looking for. I told you about sharp teeth. I told you about mountains. This last thing is about mountains where we roll out MI. But remember, a 12-lead ECG does not rule out MI. We need to keep repeating ECGs. We need to do blood enzymes. ECG may not show an MI, but an echo and enzymes may show an MI. ECG, we need to learn, but again, this is not 100% accurate. So let's look at some ECGs. So when we look at ECG, when we look at this, at these mountains, we need to look at where on the ECG they are. So this is your ECG, lead 1, lead 2, lead 3, AVR, AVL, AVF, V1 to V4, and V5, V6. If it is there in 2, 3 AVF, it is inferior wall myocardial infarction. Okay. Usually the RCA is affected. If you have it in the lateral leads, it's 1 AVL alone. Mostly it will be associated with V5, V6, 1 and AVL are lateral leads. So it's more of left circumflex involvement. And if you have V1 to V4 ST segment elevation, it is more of anteroseptal LADs. So this is how you identify what sort of MI it is. Now here you look for your ST segment elevation in these leads. Now, after this, you're looking for mountains. Yes, we know this is an MI. Now, where are those mountains? In which leads? Yes, anteroseptal MI. Okay. So you also, now in this ECG, if you look at 2, 3 AVF, you will have reciprocal changes. Wherever you have those mountains, you will have valleys nearby. Okay. So your 2, 3 AVF, you have ST segment depression, which is nothing but reciprocal changes. You see the mountains. Yes, we are able to see the mountains. Where are we seeing the mountains? Inferiorly. So you're seeing the lead, you're seeing the MI in second, third, and AVF. 2, 3 AVF means it is an inferior wall MI. And you will see reciprocal changes. You're seeing reciprocal changes in AVL and 1 in AVL. Okay. Anterior wall only. Is there are the mountains confined only to V1? There is some amount of ST segment elevation in 1 in AVL. So it's an anterolateral MI. Yes, it's involving the entire anterior wall and even in the lateral also. We've got elevation in V1 to V6 as well as 1 AVL. So to conclude, ECG readings must be considered alongside patient symptoms. You have a patient sleeping peacefully, heart rate of 50. Okay, I learned in the ECG workshop that we have to put him on oxygen. We have to put him on, don't wake up the person. So you have to consider it along with your patient symptoms. The patient is comfortable. Maybe he's an athlete. Okay. Maybe the patient is hypothyroid. So ECG readings must be considered alongside patient symptoms. I've just told you about 5 or 6 important ECGs which can be life-threatening. So every minute counts. So I hope this was a good refresher for people who don't regularly see ECGs. So mastering ECG requires ongoing practice. So even if you are into some other field of practice, whenever you see any patient who has an ECG in the file, take the ECG, look at it and try to interpret.